That number your doctor reads out, the one you've been anxiously Googling and comparing to a chart, may be telling you almost nothing useful about your actual health. Not because blood pressure doesn't matter, it matters enormously, but because a reading of 132 over 84 means something completely different if you're 38 than if you're 68. And almost nobody, not the chart on the clinic wall, not the general guidelines you find online, tells you that. What I want to do in this video is fix that, because the gap between knowing your number and understanding your number is where real health decisions live. Hi, I'm Dr. Kalb. I'm a board certified emergency medicine physician and I've been practicing for over 15 years. I've seen blood pressure at both extremes. The quiet, asymptomatic patient in their 50s with a reading that looked borderline on paper but turned out to be quietly destroying their kidneys. And the anxious patient in their 30s who was convinced their 135 was going to kill them when in context it was the least of their concerns. What both of those patients had in common was the same thing. They had a number, but they didn't have the framework to interpret it. That framework is what this video is about. Over 15 years in emergency medicine, you stop seeing blood pressure as an abstract number and start seeing it as a story. The patients who come through my department in their 60s and 70s with strokes, with heart failure, with the kind of kidney disease that requires dialysis, when you look back at their histories, the warning signs were almost always there. A reading in their 40s that hovered in the 130s, a decade where nothing was done because it didn't feel urgent, because they felt fine. And then there's the other group, the ones who show up for something entirely unrelated and happen to mention that they've been quietly worrying about their blood pressure for years, monitoring it twice a day, cutting every grain of salt from their diet, anxious every time the cuff tightens. And when you look at their history in the context of their age and their physiology, their reading was never dangerous. The anxiety was doing more damage than the number. Both of these outcomes trace back to the same failure, interpreting a number without understanding what it means for a person at that specific stage of life. And this video breaks down exactly why that happens and how to read your own number correctly. We are going to explore why the 120 over 80 target is not a universal truth, why your arteries age in a way that completely changes the risk equation, how your brain physically rewires itself around high blood pressure, and why that matters more than most people realize. What the research actually says about optimal targets decade by decade from your 30s to your 70s. Why white coat hypertension and masked hypertension are two of the most underdiagnosed conditions in primary care. And most importantly, what you can actually do about all of this in your real daily life without a prescription and without panic. Before we get into it, I want to mention something quickly. I hear regularly from people who've been watching these videos for months and then realize they weren't actually subscribed. They were missing new content entirely, sometimes for weeks at a time. If that's you, just tap subscribe now. It costs you nothing, and it means you'll see the next video when it comes out. And if you're already subscribed, genuinely, thank you. You're not just a passive viewer, you're part of something that I think matters, which is putting real clinical knowledge into the hands of people who can actually use it. Now let's get into this. Mechanism 1, the population average problem. Let's start where most conversations about blood pressure go wrong. The 120 over 80 guideline that you've seen everywhere. On posters in waiting rooms, in the health app on your phone, in almost every article you've ever read about this, is a population average. It was derived from studies looking at large groups of people and asking, across this entire population, what level of blood pressure correlates with the lowest rate of cardiovascular events? That's a useful question, but here's the problem. When you apply a population average to an individual person, you lose enormous amounts of information. Because blood pressure risk is not a flat line across age groups. The relationship between pressure and damage is steep and early in younger adults, and then it shifts, sometimes significantly, in older ones. The same reading that puts a 42-year-old at meaningful risk of a cardiovascular event in the next decade may be within a completely acceptable range for a 74-year-old whose arteries have adapted to that level over decades. Think of it like speed limits. A blanket 60 miles per hour limit might be appropriate for a motorway in dry conditions. Put the same limit on a mountain road in fog and it becomes dangerous. Remove it on an empty salt flat and it's needlessly restrictive. The number alone tells you almost nothing. The context, the road, the conditions, the vehicle is everything. Your age is the road. Your physiology is the conditions. And the number on the cuff is just the speedometer. For a real person, this means that the first question to ask when you look at a blood pressure reading isn't, is this above 120? It's, what does this number mean for someone of my age with my history in my body? And to answer that, you need to understand what actually happens to the cardiovascular system as it ages. Mechanism 2, arterial stiffness, the silent aging process. Here's the mechanism that changes everything, and it's one that most people have never heard explained properly. Your large arteries, particularly the aorta, which is the main highway of blood leaving your heart, are not rigid tubes. In youth, they're elastic. They stretch when the heart contracts and recoil when it relaxes, acting like a biological shock absorber. This elasticity is what keeps pressure smooth and distributed. But starting in our mid 30s and accelerating significantly after 50, those arteries lose that elasticity. The proteins that give arterial walls their flexibility, elastin in particular, begin to degrade and are replaced by stiffer collagen fibers. The arteries literally harden. Research suggests that by age 60, aortic stiffness has increased by a factor of 3 to 4 compared to early adulthood. Imagine a car suspension system. In a well maintained car with fresh shock absorbers, the ride is smooth. Bumps are absorbed before they reach the passengers. Now imagine the same car with worn, rigid shocks. Every bump travels directly into the frame. That's what arterial stiffness does to the cardiovascular system. When the heart pumps against stiff arteries, that pressure spike has nowhere to absorb. It transmits directly downstream into the delicate microvessels of the brain, the kidneys, and the eyes. Structures that were never designed to receive that level of pressure pulsation with every single heartbeat, every single day, for decades. This is why in older adults, it's the systolic number, the top number, that clinicians now pay closest attention to. In younger adults with flexible arteries, the bottom number, diastolic pressure, is often more informative. But after about age 55, rising systolic pressure with a normal or even low diastolic becomes the dominant pattern and the dominant risk. Studies suggest that isolated systolic hypertension in people over 60 is one of the strongest predictors of stroke, not because the body has suddenly become fragile, but because decades of silent arterial stiffening have finally accumulated to a point where the pressure spikes simply can't be cushioned anymore. But here's what makes this even more serious. The place in the body most vulnerable to those pressure spikes may surprise you. Mechanism 3, what elevated pressure does to the brain over time. I want you to stop for a moment and think about dementia, not as something that happens to other people, not as an inevitable consequence of old age, but as something with a measurable, modifiable risk factor that most people don't know about. Because here is something that the research now shows with remarkable consistency. Sustained elevated blood pressure in midlife, specifically in your 40s and early 50s, is one of the strongest known modifiable risk factors for Alzheimer's disease and vascular dementia. Not old age hypertension, midlife hypertension. Studies have followed people for 20 and 30 years, and found that those with elevated blood pressure in their 40s had significantly higher rates of cognitive decline decades later, even after controlling for every other known risk factor. The mechanism involves two things. First, the microvessels in the brain, the tiny capillaries and arterioles that supply blood to individual regions, are directly damaged by sustained elevated pressure. They thicken, they narrow, they sometimes rupture in tiny subclinical bleeds that accumulate silently. Second, the brain has a self regulating system called cerebral autoregulation that normally keeps blood flow stable across a range of pressures. But when pressure has been elevated for years, that system adapts. It recalibrates to expect higher pressure. And when pressure eventually normalizes, either through medication or lifestyle, the brain can actually be temporarily underperfused. It has forgotten how to work at lower pressures. Think of it like a thermostat that's been running at 28 degrees for so long that when the room finally cools to 22, the system reads it as dangerously cold. That recalibration is one reason why treating hypertension in older adults requires far more care and gradual adjustment than treating it in a 40-year-old. The brain has literally restructured itself around the high pressure. For a real person, this should land as urgency, not panic, but urgency. The damage from a decade of elevated pressure in your 40s does not announce itself. It doesn't give you headaches or warning signs. It accumulates silently in the white matter of your brain, in the filtering units of your kidneys, and it shows up 20 years later as memory loss, confusion, or a stroke that comes without warning. The window to interrupt that trajectory is now, while the damage is still reversible, while the system still responds. Mechanism 4, decade by decade, what your number actually means. Now let's get specific, because this is what most videos and most doctor conversations leave out. The concrete, decade by decade interpretation that actually tells you where you stand. In your 20s and early 30s, blood pressure should be genuinely low, not at the ceiling of normal, actually low. Research consistently shows that for this age group, even readings in the upper 100s and 10s to low 100s and 20s are healthier long term than readings in the 100s and 30s. At this age, the arteries are maximally flexible, the cardiovascular system is at peak resilience, and a consistent reading above 125 or 130 in someone under 35 is a signal worth investigating. Not because it's an emergency, but because it usually reflects something fixable: excessive sodium, poor sleep, physical inactivity, early signs of metabolic dysfunction. And fixing it at 30 has a compounding return over the next 40 years that no medication can replicate. In your 40s, this is the decade that matters most, and the one where people are most likely to underreact. A reading of 135 over 85 in a 45-year-old feels mild. It doesn't produce symptoms. The person feels fine. But this is precisely the window that research identifies as the highest consequence period. Arterial stiffening is accelerating. Cerebral autoregulation is being set. The kidneys are beginning to accumulate the early markers of hypertensive nephropathy. And the compound interest of a decade of elevated pressure in your 40s will be paid with interest in your 60s and 70s. In your 50s, the systolic number takes over as the primary concern. Research now suggests that for adults in their 50s, keeping systolic pressure below 130, or ideally below 125, significantly reduces the risk of stroke, heart failure, and the kidney disease that follows. But the treatment calculus also changes. Lifestyle interventions that were highly effective in your 30s remain important, but they often need to be combined with a frank conversation with your doctor about whether medication is appropriate. The threshold for medical management is lower in this decade than in the ones before it. Not because the body is giving up, but because the window for preventing damage is narrowing. In your 60s and beyond, the picture becomes more nuanced, and the blanket 120 over 80 target actively does harm when applied without thought. For adults over 65, particularly those with existing arterial stiffness, driving systolic pressure below 120 aggressively can cause orthostatic hypotension, the dangerous drop in pressure that happens when you stand up too quickly, leading to falls, fractures, and in severe cases, stroke from underperfusion. Studies have found that in adults over 75 with frailty, tighter blood pressure control actually increases mortality. The optimal target shifts upward, often toward 130 to 140 systolic, and must be calibrated individually. What your 75-year-old parent needs from a blood pressure conversation is completely different from what you need in your 40s. The number is the same, the meaning is not. But there is one more piece to this that almost nobody talks about, and it may explain why your blood pressure readings are inconsistent in ways that confuse both you and your doctor. Mechanism 5: White coat hypertension, masked hypertension, and the measurement problem. Here's something I see constantly in clinical practice that almost never makes it into patient conversations. There are two conditions that sit on either side of accurate blood pressure measurement, and both of them are leading to wrong decisions every single day. The first is white coat hypertension, the well documented phenomenon where blood pressure rises specifically in a clinical setting due to the anxiety of being measured. Studies suggest this affects somewhere between 15 and 30% of people who have been diagnosed with hypertension. Their blood pressure in the clinic looks elevated. At home, monitored consistently, it's completely normal. These people are sometimes put on medication they don't need. The second condition is the opposite and far more dangerous. Masked hypertension describes the patient whose blood pressure looks normal or even low in the clinic, where they're calm, seated in a familiar environment, but is consistently elevated in their real daily life, at work, during commutes, in the evening. These people are told they're fine, they leave the clinic reassured, and all the while their vasculature is absorbing that pressure damage hour after hour, day after day, without anyone knowing. Research estimates that masked hypertension affects around 10 to 20% of the adult population and carries cardiovascular risk equivalent to confirmed hypertension, often higher because it goes undetected and untreated for longer. This is why home monitoring with a validated cuff at a consistent time of day in a rested state, measured twice and averaged, is not optional if you're trying to genuinely understand your blood pressure. It's the only way to distinguish between a real number and a situational one. A reading taken once at a clinic visit is a snapshot. Your actual blood pressure is a film, and you need to watch more than one frame to understand the story. Think of it like checking your bank balance on the day your salary arrives versus checking it 3 days after rent has gone out. The number on any given day tells you something, but the pattern across weeks tells you the truth. So let me give you a realistic framework that fits into normal life. Not a list of aspirational targets, but a set of actual behaviors with real evidence behind them. Daily, measure correctly. This is the foundation everything else rests on. Use a validated upper arm cuff, not a wrist monitor, not a phone sensor. Sit quietly for 5 minutes before measuring. Measure twice in a row and record the average. Do this at the same time each day, either morning before coffee or evening before bed. A consistent, accurate baseline is worth more than any single intervention. For diet, the evidence is strongest around two things: reducing sodium from processed food sources, not by eliminating salt from your cooking, but by dramatically cutting the ultra processed foods that account for 70 to 80% of sodium intake for most people, and increasing potassium from whole food sources. Leafy greens, bananas, sweet potatoes, beans. Potassium actively helps the kidneys excrete sodium and has a direct relaxing effect on arterial walls. Research shows that simply shifting the sodium to potassium ratio in the diet can reduce systolic pressure by 8 to 10 points in people with elevated readings. Weekly, 150 minutes of aerobic movement, distributed however works for your life. 3 sessions of 50 minutes, 5 sessions of 30, 2 sessions of 75. The research doesn't care about the distribution, only the consistency. Walking counts, cycling counts, swimming counts. The mechanism here is direct. Aerobic exercise causes the endothelium, the inner lining of your blood vessels, to release nitric oxide, which relaxes and dilates the vessel wall, reducing pressure. Do this consistently for 12 weeks, and studies suggest systolic pressure drops by 8 to 10 points. That is equivalent to the effect of a first line antihypertensive medication. Twice weekly, resistance training, not for aesthetics, for arterial health. Studies now show that resistance exercise, done consistently over months, directly reduces arterial stiffness, the mechanism we talked about earlier that drives so much of the age related risk. 2 sessions per week of compound movements, squats, deadlifts, rows, presses. Nothing complicated, nothing extreme. The physiological stimulus is the weight moving through a full range of motion. Sleep is not optional in this framework. Research shows that consistently sleeping less than 6 hours raises blood pressure through cortisol and sympathetic nervous system activation. 7 to 8 hours, not as a luxury, but as a cardiovascular intervention. And breathing, slow, extended exhalation breathing, specifically 5 seconds in, 7 seconds out, for 5 minutes daily, activates the parasympathetic nervous system and has been shown in multiple studies to produce meaningful short term reductions in blood pressure. The sustainability note, because this is where most people fail. The person who builds one or two of these habits into their actual existing life and maintains them for 5 years will always come out ahead of the person who does all of them perfectly for 8 weeks and then stops. Consistency is the mechanism. The dose matters far less than the duration. Here's what I want you to take away from this entire conversation. Blood pressure is not a single number with a single meaning. It is a data point in a story that includes your age, the state of your arteries, the decade of life you're in, and the trajectory you're on. The 120 over 80 on the clinic wall is not wrong. It is simply incomplete. The same reading means different things at 35, at 55, and at 75. Understanding which chapter of that story you're in is not a medical luxury. It is the difference between reacting to a crisis and preventing one. Getting this right affects not just your heart, but your brain, your kidneys, your vision, your sexual function, your cognitive independence as you age, your risk of stroke, your likelihood of developing dementia, your quality of life in your 70s and 80s, and whether your final decades are defined by function or by decline. Not just whether you live long, but whether you live well. And unlike many aspects of health that erode silently and beyond your control, blood pressure and the arterial health that underlies it is largely, profoundly, meaningfully under your control. The patients I've seen do best over the long run are not the ones who had perfect numbers from birth. They are the ones who, at some point, often after a conversation like this one, decided to understand what their number actually meant for their specific body at their specific age. And then they did something about it. Not perfectly, not dramatically, but consistently, over years. If you've been ignoring a reading in your 40s because it felt mild, you now have the context to take it seriously. If you've been anxious about a number that at your age in context is genuinely fine, you can let that weight go. And if you haven't thought about blood pressure at all yet, if this is the first time any of this has landed as personally relevant, then you're in the best possible position. Because the most powerful time to act is before the damage has accumulated, before the arteries have stiffened, before the brain has recalibrated. Your body is not a fixed system, it responds. At every age, it still responds. The investment you make in understanding and managing your blood pressure today, Not tomorrow, not after the next checkup, but today, is an investment in your independence, your cognition, your relationships, and your capacity to be fully present in your own life for decades to come. That is worth more than any number on a cuff.